So hello everybody, thank you for coming this afternoon to this masterclass on pressure ulcers. And I believe we're on live as well. So hello everybody that's joined us virtually as well. So this is a short presentation on pressure ulcers. You'll find there is some refresher in here, so going over something that you probably already know about pressure ulcers, and then hopefully we'll be able to talk about some other things that maybe you don't already know. So just starting with our quick overview and refresher of the skin, just so that we can think about it when we're thinking about our pressure ulcers and we're all talking about the same thing. Obviously the skin is the largest organ in the body. It accounts for 15% of all body weight, and it's integral to both our physical and mental well-being. If you read lots of fictional literature, it tells you it's the window to the soul, and I think if you do a robust skin assessment, it does give us a clear indication on what is going on in a patient's health. So when we're thinking about pressure ulcers, we just need to think about the different layers of the skin. So we have the epidermis, the dermis and the hypodermis, and then, as you know already, the epidermis has several layers to it, starting with stratum corneum. So just thinking about that particular structure, which we're going to go and talk about when we talk about the pressure ulcers and wounding and what actually is wounded, because we will be talking right down to the hypodermis layer. Okay. So pressure ulcers are caused by damage to the tissue, and the blood supply to the area of the skin is impaired, and that's as a direct result of pressure. It is suggested by Gillian Sola et al. That pressure ulcers, 95% of them are avoidable. And we will talk a bit later on about the 5% that are unavoidable as well. So our clinical interventions, this is a really nice pressure ulcer here, include our holistic assessment, our risk assessment, and also our preventative measures that we would include to avoid the risk factors. Okay, so in terms of the burden of care, there's been quite a lot of recent studies done about wounds and wound care. I don't know if any of you have read up on them. Julian Guest in particular has been doing quite a lot of studies about the burden of wounds, and it's deemed that it's the 2018 paper, if you were making a note of that. It's deemed that pressure ulcers are the biggest burden for pressure ulcers is obviously on primary care, and they account for 9% of all wounds. 66% are seen by the GP, 18% by the district nurses, 14% by practice nurses, and 8% is other, which could include your secondary care. Okay, so this is the European Advisory Council classification definition of pressure ulcers, which we stand by when we talk about our pressure ulcers. So a localized injury to the skin or underlying tissue. It's usually a bony prominence that is affected, the skin is affected where there's a bony prominence, or it's pressure, which is a combination of friction and shear. And then there are many contributing and confounding factors which would associate with pressure ulcer development, which I'll talk about a bit later on, and obviously then the process of wound healing alongside of that. Okay, so this is that same Julian Guest paper, just to put it into context for you. In 2018, they looked at the cost of wound care, and they estimated one per pressure ulcer, £8,720. That was for over 12 months. Obviously, the cost of managing pressure ulcers is greater depending on the severity of the pressure ulcer. So a category 1 versus a category 4 and an unstageable, the cost varies between them. It's more expensive to treat an unhealed pressure ulcer than a healed ulcer, and the primary care, as I said before, takes the burden of the cost. The biggest costs are associated with the care and treatment delivered by the primary care services, for example, the district nurses, and then the dressings and the bandages, which accounts to 15%. So the community cost incurred is 98% of all pressure ulcers. And as I say, that was done in 2018, so it's still quite current data. There hasn't been a new piece of research done since then. Okay, so just to get you all after lunch, having a nice look at our pressure ulcers there. This is what we're thinking about. Most of these, as you can see, are on heels, although we have got a nice sacral pressure ulcer here as well. So we're going to talk about categorization of pressure ulcers and assessing pressure ulcers and what factors will cause further wounding and damage. Okay, so the major causes, as I said before, of pressure ulcers is the pressure, friction, shear, and medical devices. And there has been a big increase in medical device-related pressure ulcers. I don't know if any of you have seen that while you've been out in practice. So the first thing to talk about is the cone of pressure. So when a person is lying or sitting, pressure is transferred from the external surface through the layers of the skin towards the underlying bone, which is what's depicted in the picture here. Blood vessels, subcutaneous fat and muscle are all compressed between the bone, and that's what makes the pressure more intense at the bone than it does at the area where the pressure is hitting between the patient and the external surface. So what they call this is the cone of pressure. So that pyramid-shaped gradient that you can see there, that's the highest level of pressure that is received from where the patient is sitting. And it's up to 5 times greater than the level of pressure that the patient feels on their actual sacrum. So muscles and muscle tissue are not very good under pressure. They don't cope very well, and they're very sensitive to pressure. And deep tissue necrosis often occurs, first of all, at this layer here rather than what you see down here. So you'll most often see a small reddened area where the pressure has been, which is the non-blanchable erythema. When you press it under your fingertip, it doesn't go back white. And yet the wounding and the damage has occurred already by the bone, and that's what manifests itself into your pressure ulcer. So you'll then get your tissue breakdown. These are common locations that you'll find your pressure ulcers, as I'm sure you already know, but also thinking about the back of the head, the elbow, if the patient's on their back, if they're on their side, your ear, shoulder, hip, thigh, legs, less common, and then if the patient's prone, thinking about the rib cage, the thighs and the knees. And there has been some studies about women in labour, in different positions in labour, where they've been susceptible for pressure ulcers on their knees because they've been there for such a long time. So any area that's in contact with that pressure for any length of time on that bony prominence. The other cause of pressure ulcer development is your shearing force. This is where you have 2 forces pushing apart. So one's going one way and one's going the other way in the opposite direction of the body. And this causes stretching and tearing of the blood vessels, which reduces the blood flow and increases blood pooling and leads to cell damage. So the shearing stops or reduces blood flow, and that's actually worse than that cone of pressure. That does even more damage than that cone of pressure, because that cone of pressure takes longer to do that. Friction is when there is friction between the skin and another surface, so like the patient's bedclothes, and that results in taking off the top layer of the epidermis, so the stratum corneum, which you often see, and that's that constant rubbing of the skin, and that's what causes that pressure damage. So it's like when you go out and wear those killer heels or those shoes that rub and rub, that's that friction that leads to that pressure damage. And then we have our device-related pressure ulcers. These are more complex because the device often causing the pressure ulcer could be integral to the treatment that the patient needs. Really common in ICU that with the pressure ulcers, we have lots of ICU nurses talking about that. And then also the vasopressors and the inotropes used in critical care also can have an influence on pressure ulcer development. So it's not just the device, it can be all intrinsic to that. It could also be poor positioning and fixation of equipment or poor selection of equipment, more likely to be on the head and neck rather than on that bony prominence. And it often mimics the shape of the device and deteriorates quite rapidly with that constant pressure. And this is the most common cause of pressure ulcers in children, or 50% in children are the medical device associated pressure ulcers, because children don't seem to sit around for very long. Okay, so just thinking about factors that influence pressure ulcers. Obviously, those of advancing years are more prone to pressure ulcers, 65 years and over, but particularly 75 years and over, and that's due to the friability of the skin, the dryness of the skin, because dry skin causes more friction. There's more potential to have that friction with the dryness of the skin, and the tensile strength of the skin and the robustness of the skin is impaired because of the aging, deteriorating with age. Chronic illness, so any of your chronic illnesses, list there, your diabetes, your cancers, peripheral arterial diseases, and this is due to the hemodynamic instability, so low cardiac output causes poor perfusion and undernutrition, and then it limits organ function, so that then has a direct impact and intrinsic factor for pressure ulcer development. Smoking, those people that smoke often have a reduced blood supply or circulation to particular areas and can have poor perfusion. Immobility and inactivity, where the person needs to be repositioned or moving, and there's an impairment with that. Any sensory defects or cognitive or neurological impairment, or sedatives, which would cause the patient not to move around. Malnutrition and dehydration. So dehydration will affect the integrity of the skin, and malnutrition in protein plays a major role in the production of collagen, connective tissue, and the manufacture of cell multiplication. So the ability to do that when you're malnourished and dehydrated is lessened, which puts you more at risk of developing that pressure ulcer. Non-blanchable erythema, which is your superficial reddening, that's actually your category 1 pressure ulcer, but if you have got non-blanchable erythema or any areas on the skin, then you're much more susceptible to having further pressure ulcer damage. Elevated body temperature, so if the body temperature, it has a high metabolic demand on the body, if the heat changes, and it changes tissue permeability, so that puts you more at risk of your pressure ulcer development. And also on the other side, if your body temperature is too cool, then that puts patients more at risk because of skin perfusion. Cognition of the patient and patient's posture will have a big effect, and acute or chronic illness, which is usually characterised by high levels of comorbidity. Those are all your intrinsic factors that will influence. So your extrinsic factors, which we've already talked about, are your shear, your friction, and then moisture, which we're going to go into a bit more detail talking about moisture and the difference between moisture damage and pressure ulcers, but increased ambient humidity, urinary incontinence, and any other uncontrolled moisture. Okay, so we have the European Pressure Ulcer Advisory Panel have given us a framework of how to classify our pressure ulcers, which I'm sure some of you already know. This is the standard classification for pressure ulcers. So your category 1 is your non-blanchable erythema. That's your redness to the skin. It's usually over that bony prominence that we've talked about. It can be painful, firm, soft, or warmer or cooler to the adjacent tissue. And it can also progress, as I said before, into significant tissue damage. So it's just that top layer of the stratum corneum that has been damaged by that, either that pressure or that shear and friction. So they're just a few more images to show you what your category 1 might look like in different areas. Be careful with patients with darker skin tones. This is often the first category that's missed and not picked up because it's more difficult to spot in darker skin tones, and then all of a sudden your patient's got a category 2 or category 3 and you didn't realise what was happening. So it's really important to have a really good skin assessment for your patients. Category 2 is your partial thickness skin loss, and that's of the dermis. So it looks like a shallow or open ulcer. The wound bed must be pink for us to categorise that as a category 2. So it can't have any slough on the wound bed, or it can't have any black eschar, because all of those would occlude us from being able to actually categorise the pressure ulcer. And it can present as an intact, present or ruptured blister, and it's shiny and shallow, and there's no evidence of bruising, because bruising would indicate deep tissue injury instead. Okay, so there's a nice one on the heel there. There's another couple there. So it just shows you that it just touches the top of the dermis layer there for your category 2. Obviously, in the trust, they are incident reporting from category 1 pressure ulcers. Your category 3 is your full thickness skin loss pressure ulcer. Your subcutaneous fat layer may be visible, but you can't see any bone, tendon or muscle. You might be able to see some slough on the wound bed, but it won't be able to obscure the depth of the wound, so you can still measure the level of wounding. And this category 3 does vary in anatomical location, because if it's your nose or your ear or your malleolus, we don't have subcutaneous tissue there. So obviously these are shallow, so they're much shallower. And then if it's an area of high fat area, then, as she says, they're obviously going to be much deeper. So it's a much deeper wound. Doesn't change the category of it. It just means that it's going to present as a deeper looking category 3. So there's some examples of your category 3 there, going right down to your subcutaneous fat layer. So your category 4, your full thickness skin loss, and your bone, your tendon and your muscle are all exposed here. You may again have some slough or some eschar on the wound bed, and you also may find that there is tunnelling or undermining. So there's not just the wound that you can see, but there's evidence that there's significant damage in the surrounding tissue with that tunnelling and undermining. And again, this varies with anatomical location. So I've got a nice picture here for you, where you can see here, you can obviously see a bit of slough there, but then here in this darkened area, and then a satellite wound up there, there's obviously a bit of tunnelling going on there, and then there's obviously significant damage to this to the tissue. Well, that's another nice one as well. So we only got a little bit of slough there, but then obviously we've got more non-blanchable erythema around the outside of that wound. So there's obviously some significant damage to that wound and that the pressure there. Okay, and then we have our unstageable wounds, which is full thickness loss, but the base of the wound is covered by your slough or your eschar, and until that's removed or debrided, we are unable to stage or categorise the pressure ulcer because we cannot determine the true depth. If the eschar's dry, then it's best not to remove it. It acts as a biological barrier for the body, so it just sits there and shouldn't be removed. And there's some pictures of your nice black eschar there and your unstageable pressure ulcer. Okay, more difficult to categorise is your suspected deep tissue injury. This is purple or maroon and localised area of discoloration, often mistaken for a bruise. So it's often seen, something like that might be on somebody's leg and it's mistaken that they might have fallen and had a little bruise there. Or it could be a blood-filled blister. It may be preceded by the fact that the tissue is painful, firm, mushy, boggy, or warmer, or cooler than the adjacent skin, and it's quite difficult to detect and it's harder in darker skin tones, so you do need to make sure you have a good skin assessment there. So there's your deep tissue injury. That's on a heel. It's very common with patients that wear things like leg braces and things like that. Check underneath that it's not a bruising from the leg brace. That might be a deep tissue injury or something there. And then at least half of pressure ulcers, whatever category they are considered to be at high risk of infection. So not only do we have the fact that we've got the pressure ulcer and we've got the damage and we need to go through the phases of wound healing, we also have the issues with infection and keeping them clean so that they heal. Okay, so again, this was the piece of research that was done to look at the impact of that. So if it's a category 1, it's about 1 dressing change a week because you want to keep monitoring that. A category 2, 3 dressing changes every 2 weeks. Category 3, 2 dressing changes a week. Category 4, 3 dressing changes a week. And unstageable, 2 per week. And then patients often need to be prescribed analgesia, steroids, or you might need an antimicrobial dressing, or depending on the infection, you might need antibiotics. Healing times vary, and these are healing times that they did in the study, but it will depend on those intrinsic and extrinsic factors that influence wound healing and whether the patient's got any other comorbidities, what their lifestyle factors are, any environmental factors that might be influencing their wound healing. But classically, a category 1 should take only 1.1 months to heal. Category 2 should be 5 months. A category 3 and 4, they say the average is 7.7 months, and then an unstageable 10 months to heal. So that's a long time for the patient to be in that position and constantly having to host that immune response to progress the wound to heal through the inflammatory phase has a big impact on the body. They say you need up to 250% more calories to continuously host that immune response for wound healing. Gone the wrong way. Okay, so one of the problems that we tend to have with categorising our pressure ulcers is that we have a mixture of other things going on with our patients, and one of the most common problems that we have is moisture-associated skin damage. And classification between pressure ulcers and moisture damage often gets a little bit confused. So moisture-associated skin damage is the term used to cover a range of skin problems following prolonged exposure to moisture and its contents, and that could be urine, feces, perspiration, saliva, wound exudate, or mucus. So any of those things. There are 4 forms of moisture-associated skin damage. You've got incontinence-associated dermatitis, interrigous dermatitis, peristomal moisture-associated dermatitis, and peri-wound. So just to give you a quick overview of the different ones, the peri-wound moisture-associated dermatitis is obviously exudate from the wound. When the wound's in the inflammatory phase, because the neutrophils and the macrophages have gone in to clean up the wound tends to have a higher level of exudate. So wound will exudate more whilst it's in the inflammatory phase, which is normal, and we do need moist wound healing. But an excess of exudate that goes onto the peri-wound will then macerate the peri-wound and cause the skin to break down around the wound. Interrigous dermatitis, an inflammatory condition which occurs in the skin folds. So you can see it there, and it's aggravated by heat, moisture, maceration, friction, and poor air circulation to that particular area. This particular moisture-associated dermatitis is frequently complicated by infection. So you can often have a yeast, a viral or a fungal infection that also may occur for patients that have this one. And you usually find it in any areas like the groin, the perineum, the axilla, where there might be abdominal folds. So if the patient is obese, there might be abdominal folds and you might find it there. And it's important to assess that because there can also be, if the patient has skin folds, there can also be friction and shear from skin to skin contact, which would also then cause you a pressure ulcer. So it might not be a moisture, it might be the fact that it was a pressure ulcer because of skin to skin contact causing that. Peristomal dermatitis, this one is associated with inflammation and erosion of the skin around the stoma site and the junction of the stoma site, and then that can extend to like a 10 centimetre radius, but that's quite a clear one because you've got the stoma and you can identify the causative factor. And then the most common one that is confused with pressure ulcers is your incontinence associated dermatitis, which is a chemical reaction caused by urine and feces, and the enzymes from the stool disrupt the acid mantle of the skin and break it down. And this is really painful, and the erosions are weepy, and there's a serious exudate with them. So just thinking about how we make sure that we're categorising correctly and we don't confuse the moisture and the pressure damage. Think pressure if it's on those bony prominences, so thinking of that causative factor. If it's got really good defined edges like you saw in the pictures. If you do have that eschar or that necrotic tissue, it's more likely to be pressure. If you've got damage going down to the muscle layer, because your moisture damage is more superficial. If your patient's got risk factors for pressure damage, which is your immobility and restricted mobility, and if they've had an acute illness recently, and then if this infection, because both are highly prone to infection, but it's more likely to be a wound infection rather than a superficial infection. Moisture, if it's a location, so if it's one of the locations that we talked about where there's moisture, if there's an irregular shape because it's speckled about because it's moisture damage, if the patient's incontinent or they've had a UTI or a leaking catheter, if they've got diarrhea or they're constipated, if the patient's been sweating a lot, so they've got a high temperature and they're sweating, or if, as I said, it's a superficial infection. You can obviously get both together, so you can obviously get your pressure ulcers and your moisture damage in combination, and it's about just classifying each of those wounds then. Okay, so our full assessment should include obviously the patient's continence status, their mobility, any allergies they've had, any skin problems. Talk to the patient about what they use for their bathing routine, because alkaline soaps and products disrupt the acid mantle of the skin and they're quite abrasive. So talk to the patients about using something more gentle for their skin regime. Doing your risk assessment tools, which we'll talk about later, and then doing a full skin inspection, so the palpation, the skin colour, the temperature, and whether there's any moisture present. Okay, so the only pressure ulcer that's deemed unavoidable is when it comes to end of life, and pressure ulcers at the end of life. So this is termed, the terminology that they use for this is skin failure at the end of life. So when multiple organ failure occurs, the body protects the major organs and shunts all the blood and the organs, shunts all the blood to those major organs, which then deprives the extremities and the skin. And the underlying tissue then suffers from hyperperfusion. Oxygen to the skin is depleted, nutrients are depleted, it becomes hypoxic, and the skin's not able to remove all its waste either. And that's under the skin failure at the end of life. So this manifests in those changes. When you're looking at pressure ulcers at the end of life, they present slightly differently, and obviously your causative factor would be the fact that the patient's at the end of life. They usually present on the sacrum, and they're shaped like a pear, a butterfly, or horseshoe. And they are, I've seen them in practice. Their borders are irregular, and they come on really quickly. So you could have assessed your patient, washed your patient on one day, and the next day you look at them and it's like they've got a category 3, category 4 pressure ulcer. So there's a rapid onset with those. They're deemed unavoidable, although they still have to be reported and categorised. And they have like a blush look about them, or they look like they're dirty, like maybe they need cleaning, or they've got some kind of feces or something in them. And they often get them mirroring in a bilateral presentation. They've had various names over the years. They used to be called Kennedy terminal ulcers. They've had various names, but they now sit under the skin failure end of life classification. And then in our pediatrics, the prevalence rates are as high as 27%, and that's those that are in poorly, unfortunately, and in intensive care. And they have the inability to sense the devices, because in 6 to 24 months old, they have a much thinner stratum corneum, and the epidermis has no direct blood supply. They get oxygen and nutrients from the dermal layer until they grow and develop. They're more likely to leave scars on them, and they're quite distressing for the youngsters. So the advice suggested to manage and prevent, if possible, device-related pressure ulcers is correct positioning of the device and taking care of the equipment, and then using some barriers to protect that skin under the device, so film dressings, hydrocolloids, to stop that moisture, that friction and the shear, and then the use of pressure reducing dermal gel pads, so anything that you can put underneath to stop that shear and friction being caused. So your skin assessment is really important and integral to identifying the risk factors of pressure ulcer development, the early assessment and early identification of that, just by having a good look from head to toe at the patient's skin and thinking about those intrinsic and extrinsic factors. So early assessment and regular assessment. Keep those that finger palpation on areas of the skin, and check for any areas where the skin integrity is compromised. And then the skin acronym has been developed. I think you've probably all used this out in practice, haven't you? So as an aid, it's been used as an aid memoir to try and support staff in how to remember what to do. So it's the skin acronym. So I'll talk you through it anyway, but you probably know it. So the surface. So the first S starts for surface. So that's to make sure all the equipment and support surfaces are in place, to make sure that any pressure relieving devices or services are there and they're being used correctly, and the patient isn't using their pressure relieving cushion as a backrest. So checking all the surfaces are correct. Then for the skin, assess the fragility and the risk of the skin. So what does the skin look like? Assess all the vulnerable areas over the bony prominences, to look at all of those. Assess any contact with your medical devices. Apply your finger pressure. If you do have the non-blanchable erythema, then you need to reassess every 2 hours until that resolves. So that's quite a lot, certainly for patients that are in the community. Assess the hygiene of the patient and remove any soiling or any moisture. And I've talked to you about removing any alkaline products that they might use, and then protect all vulnerable areas. So you could use your films, your hydrocolloids, anything like that to protect them, and then use a barrier cream. Oh, I moved on too soon, sorry. Keep moving is the K for the skin. So you need to reposition your patients every 4 to 6 hours. Don't turn them onto reddened areas if you can help it. So if you can reposition them but don't put them onto reddened areas. Massage for damage to the skin is contraindicated. So giving them a nice massage is contraindicated to that, and ensure that the pressure relieving equipment is in place. The National Pressure Ulcer Advisory Panel recommend a 30 degrees tilted side lying position. I admit that that's not always possible, but something to aspire to. And try to avoid your patient slouching, because you're constantly causing that shear and friction if they're slouching. Ensure its pressure is redistributed. Don't drag the patient, so it's about managing your moving and handling, because the minute they're dragged up the bed, that's that friction that will cause that. And check the positioning of any medical devices. With your incontinence and moisture, we've talked through that. That's just a regular assessment and mitigating those risk factors. And then for nutrition and hydration, use your risk assessment tools, which I'll talk to you about, your Waterlows or whatever tools you're using. And the suggestion is referral to the dietitian, because if a patient is at risk of being of pressure ulcers due to malnourishment or hydration, they might need supplements. The other option is to talk to your patients and educate your patients about supplementing their own diets, so fortifying their own protein intake, their own calorie intake. When a wound is healing, a patient needs to have an additional 40 calories a day, so talk to them about fortifying that, and also their vitamin intake, particularly vitamins A and B. Thinking about your types of pressure relieving equipment and what you should use. There are loads of types of pressure relieving equipment for patients. This table just talks about patients who've been admitted into secondary care. So thinking that they need to go straight onto high specification foam mattress, and then if they're high risk, if they're immobile, looking at alternating airflow mattresses for them. If they're going to surgery, then they need high specification foam mattress or redistributing advice. For the cushions, there are gel cushions, foam cushions, or alternating air cushions. And for heels, there are heel pads that you can put on, or heel boots, like they look like the Roho cushions, and they're pressure relieving boots. So thinking about the right equipment that the patient needs to relieve that. Your risk assessment should be carried out within 8 hours of admission to caseload, and then a reassessment should occur based on if there's any changes in the patient's needs and their condition, if they deteriorate, or on a regular basis. So you need to reassess anytime anything changes. Okay, so we have several risk assessment tools that we use in the UK, but the most commonly used is the Waterlow score. Do you all use the Waterlow score? Yeah. There isn't any conclusive evidence to say one risk assessment tool is better than the other, and they are deemed to be very subjective and based on the ability of the person that is carrying out the risk assessment tool. So there's quite a high degree of subjectivity within your risk assessment tools, but they are what they are, and they've got what we have, and they give us a guideline. They don't ever take away clinical judgment. The tools that we have here, they do miss out a few things, so there are other intrinsic, extrinsic factors that could be included, and there's been lots of research about the subjectivity of tools, but as a new tool comes out, it's open to its own level of criticism. But they could include things like ethnicity, which would be really helpful, things like low blood pressure, lifestyle factors, does the patient smoke or drink large amounts of alcohol. All of those will have an impact on their tissue perfusion. So I have the risk assessment tools. I'll show you on the screen. I've got some here for you. So this is the one that's classically used, as you say. This is your Waterlow tool. The this goes through each category, so it focuses on body, BMI, body mass index, whether the patient is continent or not, what the skin integrity looks like, and their mobility. They score higher here for females, and it doesn't say in the evidence that females are more susceptible to pressure ulcers. I've looked at the recent research and it's not coming up. So, but you do score higher on this one if you are a female. And then malnutrition screening, and whether there are any special risk factors, that the patient's got diabetes or paraplegia or has had any surgery or trauma. And you can't see at the bottom, so it goes from at risk, high risk, and very high risk. This is the Braden scale. This is slightly different tool. Have anybody used this one from the Waterloo? This is used in some trusts and some areas, and it's got much more descriptive narrative with it, but it doesn't have all the parameters that the Waterloo has. So it talks about, it gives you a description of what very limited looks like, what very moist looks like, what inadequate looks like, and it gives you full descriptive factors on that, on how you complete that one. So that's used in certain areas. Some ITUs have been using that one. We also have the Norton scale. This is a really old scale that just talks about physical condition, mental condition, and activity. We do a lot of tests with this on the tissue viability module, where we use all of these for case studies, and they all come out the same. They're all very subjective. There isn't any particular evidence to say one tool is particularly better than the other. And we do try them out. And then this is the Purpose T. This is the newest pressure ulcer screening tool that's used. There are some here if you can't see it on the screen. This one very much takes you through mobility, skin, and clinical judgment, and then straight down to your assessment and decision, depending on, there might be some other interesting factors that you might need to think about in between. But it's a very, it's a different tool. It focuses on nutrition, it's got medical devices in there, it's got more about moisture in there. So what they tried to do there is cover a few more of the factors, the intrinsic or extrinsic factors that might influence pressure ulcer development. It is used in some trusts, but it's not widely been used. So the integrity of your pressure ulcer tool is based on how well the person fills it out, and how well that is then handed over to the next person. So that is that's as good. It is as good as it is for someone completing it. Also should be used in line with your MUST tool. So your pressure ulcer tool is with your MUST tool, which is your universal screening tool, and I think everybody uses that, don't they? To check whether patients are malnourished or at risk of malnourishment, or whether they're obese. And that also sits in the parameters of BMI, weight loss, whether they have an acute disease, an overall risk, or and then talks about management guidelines for that. Okay. So that's the end of my presentation. Did anybody have any questions?
Sorry, from the skin assessments, there is a SK. What does the acronym and can you explain?
The skin,
Yes.
SSKIN.
Yeah.
That was this one. Here.
Yeah, that was.
So it's the surface, skin, keep moving, incontinence and moisture, and nutrition and hydration.
Forward. Yeah, that one, last one then.
That's it.
That's it. Yeah.
That's it.
Okay.
Yeah, that's that one. Sorry, I probably confused. So it's just broken it down into that. So that it's just an aid memoir. It's just to try and get you to think when you're out in practice. I've got to think about the skin, and then you go through each of those. That's all the acronyms for. to try and get practice style. There's so many devices, turning clocks are used, lots of things to try and, but you know, when it's that busy out in practice and there's lots going on, trying to remember to reposition your patients, doing that thorough skin assessment, all of that. So these are the kind of things that they come up with.
Can I ask a question?
Yes, please.
One of the elements you mentioned about the assessment, you know, obviously was looking the color that you identified very well. You mentioned a couple of times palpation. What element of palpation you do?
So you're just pressing the skin. It's just a finger palpation. So you're just pressing the skin, and if it then goes white underneath the finger, then that's that's blanchable erythema. So you're looking for the non-blanchable erythema, which would be your category 1.
Thank you.
Any other questions? No? So I've got some handouts for you all that are here, and those that are online, you can get them, they're in the library. So it's just an article on pressure ulcers, an article on moisture-associated skin damage, one on pressure ulcers at the end of life, and one on skin assessment in adults.